And rheumatology or clinical immunology, as it is called, is at the center of the fulcrum. That's basically where everything happens. Once you place disease in their respective pockets, we can easily get to answers. Rather than studying everything and then trying to answer, let us try to get a wholesome understanding where you want to place the diseases. Let us try to get in crux of that. The model for all the diseases that we are actually studying under rheumatology, the core central model itself is rheumatoid arthritis. And many people before watching the model may be under the impression that this is a specialty that caters to RA mostly, but no, there are a large number of diseases. Rheumatoid arthritis is at the central point. Okay, rheumatoid arthritis is the central point. So I'm asking you, what is rheumatoid arthritis? Then your answer must be that this is a multi-system autoimmune CKD. So multi-system autoimmune connective tissue disease. So I will add on to that and I will say this is the most common multi-system autoimmune CKD. So most common multi-system autoimmune CKD is rheumatoid arthritis. Second most common multi-system autoimmune CKD, many people get it wrong. Many people think it is SLE, but it is not SLE, it is Sjogren. So Sjogren syndrome is the second most common multi-system autoimmune CKD. RA is the most common. So then you are asking me, how can we actually kind of build up? So then I'm saying the key word here is that it is the most common multi-system inflammatory autoimmune CKD. This is the most common multi-system inflammatory autoimmune CKD. Now, why this inflammatory word is very important? This inflammatory word is very important because inflammatory issues are what the rheumatologist deals. Non-inflammatory issues are generally not dealt by the rheumatologist. It is dealt by the orthopedician. So, meaning that there is another category called non-inflammatory issues, or we say non-inflammatory issues where the predominant component is in the joint. So we can call it as non-inflammatory arthritis. And the prototype example is osteoarthritis. It is the most common arthritis, actually speaking. Case-wise, it is more common than RA. So most common arthritis is OA. Most common multi-system autoimmune inflammatory CKD is RA. And OA is a non-inflammatory arthritis, which means that here the word inflammation becomes very, very important. So if you're having to put it as inflammatory autoimmune CKD, what will be the defining point in this? Defining point is definitely arthritis. There is no question about it, correct? Defining point is arthritis. Although so many things are there, it is arthritis that defines. So when you want to actually talk in detail about arthritis, so we have actually got this much correct, right? When you want to talk in detail about arthritis, then you must be looking at there are intra-articular structures, there are extra-articular structures. So the moment somebody comes to with a pain or swelling or anything for the matter, you want to know whether you are dealing with an intra-articular problem or extra-articular problem. Because extra-articular problems include the problems concerning the ligament, the tendon, the muscle, the fascia, etc. And these are all generally dealt with by the orthopedician. So these are not dealt with by the rheumatologist. They're all dealt with by the orthopedician. That's why to differentiate this is very, very important. And intra-articular structures actually include our synovium. Very, very important. Then the hyaline cartilage, or what we call as the articular cartilage. It also has the intra-articular joint capsule. Yes, intra-articular joint capsule. So synovium is there, articular cartilage is there, intra-articular joint capsule is there. All these things come under the intra-articular portion, and there is an extra-articular portion. Intra-articular portion is purely the domain of the rheumatologist. So whenever you see a patient with some kind of a pain or swelling or anything, your main point is to say whether it is intra-articular or extra-articular. What actually helps us to say whether it is intra-articular or extra-articular? First thing, whenever you are having a diffuse pain, okay, not along the joint line or anything, you are having completed it.
हेलो भाइयों, हेलो हेलो, फटाफट अभी कमेंट करो अगर कुछ कहना है तो, फिर आधे घंटे बाद 9 बजे, 8:24, 9 बजे फिर बात करेंगे। अभी कुछ बोलना है तो। If you want to say anything, just write, just write. And after this, we have to talk to 9 p.m. Okay, so no one wants to talk. We we'll now direct talk at 9. It's 8:25 right now. We will now talk at 9. Stay tuned.
Diffuse pain, which is more deep-seated in contrast to a more localized superficial pain. So diffuse deep-seated pain to a localized superficial pain is the first point of difference. Whenever you are having a diffuse deep-seated pain, it's very likely to be intra-articular pathology. Second point is pain on active and passive motion. So pain on active and passive motion is seen in the intra-articular pathology, whereas pain is only on active motion in an extra-articular pathology. Passive motions are actually perfectly painless in an extra-articular pathology. Third point is when you are seeing swelling, when you are seeing crepitus, when you're actually seeing deformity, etc., it is very much equal to intra-articular pathology. Whereas you may see a localized swelling away from the joint in an extra-articular pathology. So localized swelling away from the joint in an extra-articular pathology. So this is very easy to differentiate. As and when you see a patient, the first question is whether
Just a minute.
Yeah.
I should be handling this or I should be sending it to the operation. You sit in an OP also, that is the single most important thing. And as far as your exam is concerned, diffuse deep-seated pain, generalized swelling, pain on active and passive motion, pain fully around the joint, all these things are so very classical of intra-articular pathology. We are actually going to deal with intra-articular pathologies. But remember that our intra-articular pathologies can have a small extra-articular component also. That may be possible. But actually speaking, what are we going to study? We are going to study core intra-articular pathologies. Okay, now let us try and see what are the intra-articular pathologies that we are going to study. So when you look at this word called intra-articular pathology, I told you the first major structure is the synovium. And when synovium gets involved, it is called synovitis. When synovium gets involved, it is called synovitis. And the prototype example for synovitis is RA. So whenever you think of RA, from now on, don't think of the word arthritis. It's better to put it as intra-articular. And in intra-articular, it is equal to synovium. That is why it is equal to synovitis. So what is basically RA means? I would use the word chronic here, and chronic means more than 6 weeks. That's very important to understand. It's more than 6 weeks. Chronic inflammatory
Multi-system autoimmune CTD. Most common.
CTD, where the defining point is chronic inflammatory synovitis. So the defining point is chronic inflammatory synovitis, and synovitis is associated with synovial hypertrophy. This synovial hypertrophy is what that actually is equal to a pannus, and this pannus is the one that causes bone erosion. So this is the basic point about RA. Okay, now the major structure that I am talking about is the articular cartilage. And what is the prototype example for a disease that involves the articular cartilage? That is osteoarthritis. So when you think of OA, it is the articular cartilage that has to come to your mind. When you think of RA, it is a synovium that comes to your mind, which actually helps you differentiate.
OA, articular cartilage. RA, synovium. OA is equal to articular cartilage. RA is equal to synovium.
A lot of things. And here, it is completely non-inflammatory. So non-inflammatory affecting the articular cartilage. And what are the characteristic features? Characteristic features are loss of joint space. Okay, osteophytes. Very, very important. And subchondral sclerosis. So loss of joint space, osteophytes, and subchondral sclerosis. This is what identifies OA.
And it's non-inflammatory.
So synovium is there, articular cartilage is there, and you know these are the basic points of difference. That means we are now trying to place arthritis in any one of the pockets, and then we see the pattern of joint involvement, etc. And the exam goes, what are the inflammatory arthritis ratings that we need to be knowing? First, of course, is RA. Okay, first of course is RA, and along with that SLE, and SLE-like arthritis. So SLE and SLE-like arthritis. SLE-like arthritis means mostly Sjogren and also polymyositis, dermatomyositis. This is what it is. So in all these conditions, it is the synovium that is the problem. So we call it as synovitis. It is basically synovitis. Differences we will actually see. Second major chapter that we are going to study is called spondyloarthropathies. Okay, or spondyloarthritis. Okay, spondyloarthritis. In spondyloarthritis, we have axial predominant spondyloarthritis, what we call axial SPA, and then we have peripheral SPA. So axial predominant spondyloarthritis is there, peripheral predominant spondyloarthritis is there. Axial SPA is characterized by sacroiliitis that we will see. So it's an axial involvement, sacroiliitis. For example, is ankylosing spondylitis. So ankylosing spondylitis where it is sacroiliitis. You can call it as bilateral sacroiliitis. Correct? Now, peripheral SPA or peripheral predominant SPA, you can call it. You can't call it as completely peripheral. So peripheral predominant spondyloarthritis, we have very important two conditions to study. One is psoriatic arthritis and the other one is reactive arthritis. So psoriatic arthritis and reactive arthritis. But how do you know that psoriatic arthritis and reactive arthritis are different? Because here it is not just a synovitis that you are talking about. There is also enthesitis, there is also dactylitis. So when I talked about RA, I was using the word synovitis. In psoriatic arthritis and reactive arthritis, I'm talking about synovitis with enthesitis. Enthesitis means enthesis inflammation. Enthesis is the site where ligament, tendon, capsule, fascia, all these things get attached to the bone. There is inflammation, classically Achilles tendon you look for, or plantar fasciitis you look for. Those are the examples. We'll come to that. So enthesitis is there and swelling on the finger, which is called dactylitis. So synovitis plus enthesitis plus dactylitis is called as your spondyloarthritis. So that's the second major heading that you are going to see. Third major heading is crystal arthropathy. So when you talk of crystal arthropathy, then you are talking about two crystals, predominantly MSUM crystal and CPPD crystal. Monosodium urate monohydrate crystal, calcium pyrophosphate dihydrate crystal. So these two crystals are there, which some people call as gout and pseudogout, but better to call it this way. These are two diseases where you are having synovitis due to the crystal. So synovitis due to the crystal is basically what is equal to crystal arthropathy. So now you know what are the major headings that we are actually going to study. And now with the help of questions which we are going to ask, we will try to place diseases in each of the pockets. There are few more diseases that we need to know with respect to arthritis. Also, we need to know about septic arthritis, that is also there. But this is the general platform on which we are going to build. Right? Now let us try and see the most important questions. So when a patient comes with symptoms, what is that you want to know? First thing you will ask the patient is this an intra-articular versus extra-articular pathology? That I already told you, because if it is extra-articular, then you have nothing to do. Your next major aim is to know whether it is an inflammatory versus non-inflammatory pathology. We will see that. So inflammatory versus non-inflammatory pathology. Is it a unilateral or a bilateral pathology? Is it a symmetrical or asymmetrical pathology? So symmetrical or asymmetrical pathology, unilateral or bilateral pathology. Is it a monoarthritis or oligoarthritis or polyarthritis pathology? Which means more than 5, more than or equal to 5 is equal to polyarthritis. 2 to 4 is oligoarthritis. Then is it a small joint or a large joint pathology? Small joint or a large joint pathology. Is it an axial or a peripheral pathology? So this, they can be overlapped. You will look at the predominant components. So intraarticular or extraarticular, inflammatory or non-inflammatory, unilateral or symmetrical or asymmetrical, mono or oligo, small joint or large axial peripheral. This is what you're looking for. Now let us try to take the classical prototype example of RA and try to fit into this pocket. Is it intraarticular versus extraarticular? Definitely RA is an intraarticular issue. So intraarticular, you know the most important site involved is the synovium. But always remember, RA is not a pure intraarticular issue. We can have tenosynovitis in RA. Tendency, the information is there. Flexor tendon tenosynovitis is a common component. So don't say that RA is purely intraarticular. Tenosynovitis is also there in RA. So keep it that way, but intraarticular more common. Inflammatory versus non-inflammatory. So from a clinician perspective, how will you notice? Best test to say whether it is inflammatory or non-inflammatory. Synovial to WBC count, the moment it is more than 2000 per microliter, you call it as inflammatory. Otherwise, you call it as non-inflammatory. But we cannot have the synovial fluid in a patient who comes to our OP. So the single most important thing that we can look for is morning stiffness. That is the single most important thing. The moment the patient says that they are having a morning stiffness which is lasting for more than 45 minutes, which is going away with activity, that is equal to inflammatory. So the key important question that we need to ask is morning stiffness. That is a peripheral arthritis, morning stiffness duration is 45 minutes. Patient will say that there will be pain, tenderness, inflammation, swelling, everything in the morning, which goes away with activity. So the second most important question is inflammatory versus non-inflammatory, where you know that morning stiffness will help you answer. Is it unilateral or bilateral? RA is bilaterally symmetrical. Correct. Is it mono, oligo, or polyarthritis? It is peripheral, small joint, polyarthritis. So bilaterally symmetrical, peripheral, small joint, polyarthritis. And if I've got a question, is it upper limb or lower limb? It is peripheral, small joint, upper limb, polyarthritis. This is called R.
Bilaterally symmetrical, upper limb, small joint, peripheral polyarthritis.
Chronic synovitis. So what is this? It is a chronic synovitis which is inflammatory, which is bilaterally symmetrical, which is peripheral, small joint, upper limb, polyarthritis. This is very, very clear. And the same picture can be actually seen in SLE and SLE-like arthritis. So the same picture can be seen in SLE and SLE-like arthritis. That is why they are actually close.
Hmm.
This is the picture that you see. Okay, this is very clear. So that brings us to the very important MCQ question. How will you differentiate between the two? How will you differentiate between the two? How you differentiate between the two is the most important part, is based on the X-ray. Because in RA, you are looking for a very important finding, and that is erosion. Erosions are seen in RA. Erosions are absent in SLE and SLE arthritis. If you look for the joint, you will understand that there are margins of the synovium which are not covered by articular cartilage. The one in orange is the synovial membrane, the one in blue is the articular cartilage. You can see that this is a portion of the bone which is lined by synovium but not actually covered by articular cartilage. So it is here that you see erosions mostly. This is called juxta-articular osteopenia. So the classical word is juxta-articular osteopenia, or you can even call it as marginal, because these are the margins of the synovium which are not lined by articular cartilage, but the correct word is juxta-articular osteopenia, and that is what I'm looking on this X-ray. As and when I see this X-ray, yes, I can see an erosion here. I can also see an erosion here, so I'm actually able to make it out. And there is going to be some degree of demineralization. It's not that white. That's not for you. Why we are taking the X-ray is not to see anything. We're just looking for erosion. So very clear, RA will have erosion. That brings us to a very important question. What are the causes of erosive arthritis in rheumatology? So the most important cause for erosive arthritis in rheumatology is RA. Apart from RA, where else can you get erosion? Now let us come to, so we're talking about peripheral here. Okay, I'm not talking about the axial ones, mostly peripheral. Peripheral, when you talk of, second major heading what we studied spondyloarthritis there, psoriatic arthritis, very well known to produce erosion. So psoriatic arthritis is the second answer. The third is what we studied, crystal. Acute crystal arthropathies are not erosive, but chronic crystal arthropathies are by themselves erosive. So chronic crystal arthritis, again, very erosive. So RA is erosive, psoriatic arthritis is erosive, chronic crystal arthritis is also erosive. Chronic crystal means MSUM as well as CPPD, which MSUM more classically. Okay, MSUM more than CPPD. These are the three main causes. Another very important cause that you have to keep in mind is multicentric reticulosteolysis. This will again study. This is more paraneoplastic and involves the DAP joint, etc. But this is also erosive. So RA is erosive, psoriatic arthritis is erosive, chronic crystal arthritis is erosive, multicentric reticulosteolysis is erosive. When you think of erosive arthritis, these are the names that have to come to your mind. Okay, same way you should be knowing what is non-erosive. Non-erosive arthritis, the first example that has to come to your mind is SLE and SLE-like arthritis. Very important. SLE means you will never see erosion. If you see erosion in SLE, that is called lupus. That is RA-SLE overlap. If you are just seeing SLE, that is never going to be erosion. Erosion in SLE is equal to lupus, RGBUS, which is RA-SLE overlap. Second thing is acute rheumatic fever. Okay, acute rheumatic fever is where this non-erosive arthritis was first described. That is also called as Charcot arthropathy. We'll come to that. Charcot arthropathy is the name that we use for these non-erosive arthritis. That is acute rheumatic fever. The second example. The third example is acute crystal arthritis. Okay, so chronic crystal arthritis is erosive. Acute crystal arthritis is non-erosive. And four is a condition called relapsing polychondritis. So you don't have to study anything about this, but you have to be knowing that it is of course the articular cartilage, right? The pinna that gets involved again and again. The cartilage gets involved again and again. That is pinna most commonly. It is called relapsing polychondritis. As far as relapsing polychondritis is concerned, it is very important to know that it is non-erosive. Also, it is very important to know, we will study that again, called magic syndrome. This name has been asked for exam. What is magic syndrome? Mouth and genital ulcer with inflamed cartilage. Inflamed cartilage stands for RPC. Mouth and genital ulcer stands for Behçet's disease. This combination of Behçet's disease with RPC is called as magic syndrome, and that's asked for the exam. Then we'll come to. So these are the examples of erosive and non-erosive arthritis. Okay, so I think you have a reasonable idea what are the diseases we have there.
Erosive rheumatic arthritis, SLE and SLE-like non-erosive, psoriatic chronic crystalline multicentric reticulosteocytosis, acute rheumatic fever, rheumatic arthritis, rheumatic fever, Charcot arthropathy, acute crystal arthropathy, relapsing polychondritis affects the pinna. Little laxative.
again go back to what we have been trying to see. That is to get a more decent understanding on this disease called RA. So this much is actually clear. We come to a very, very important entrance question. RA is deforming or non-deforming?
RA is deforming.
And what is the reason for deforming arthritis in RA?
Erosions.
Erosions are the reason for deforming arthritis in RA. So RA is deforming because of erosions. Is SLE and SLE-like arthritis deforming or non-deforming? Many people wrongly think that it is actually non-deforming. No. SLE and SLE-like arthritis can also be deforming, but that is not because of erosions, it is because of the laxity of the ligaments. So RA is erosive deforming, SLE and SLE-like are called non-erosive deforming. This non-erosive deforming is what we call as Jacquard arthropathy. It is called Jacquard arthropathy. It is first described in acute fever. It is called as Jacquard arthropathy. So what is Jacquard arthropathy? Non-erosive deforming. What is RA? Erosive deforming. So what reason is different between the two conditions? Okay, so I think this part is very, very clear now, and you have a very, very good understanding about this. So I now go one step ahead and see that RA is a synovitis of the small joints of the upper limb. So synovitis, which involves the small joints of the upper limb, and it is bilaterally symmetrical small joint of the upper limb. Correct? This much I know. So then I have to go and tell you what are the joints getting involved. So I'm saying that MCP is getting involved, wrist is getting involved, PIP is getting involved. These are the three classical joints getting involved. So you can see. But one joint is missing. What is that one joint that is missing? DIP is missing. Because DIP doesn't have enough synovitis. That's the reason why DIP is not getting involved here. So DIP is missing. MCP, wrist, and PIP are getting involved. Which also brings us to a very important question. What are the joints which are spared in RA? If you look at the joints that are getting spared in RA, classically DIP, first the CMC joint.
MCP, metacarpophalangeal joint, MCP. Wrist, MCP, wrist and proximal interphalangeal joint. અને એક બેન ત્રણ ઇન્વોલ્વ હોય બરાબર, એક બેન ત્રણ, ઓકે ડન. અને સ્પેડ હોય આ બે ઇન્વોલ્વ છે. તો ફર્સ્ટ મેટાટાર્સોફેલેન્જિયલ અને કાર્પોમેટાકાર્પલ. wrist નહીં, wrist તો અહીંયા થાય, કાર્પલ અને અલ્લા એ wrist joint. ઓકે, તો કાર્પોમેટાકાર્પલ.
And first MTP joint. These are the three classical joints which are spared in RA. So these three joints are never involved. And as far as the axial skeleton is concerned, thoracolumbar, sacral, they are all getting spared. It's only C-spine that gets involved. Everything from down gets spared. So these joints are getting spared, these joints are not getting spared. So it's very, very important to understand this is the pattern. Correct. Now that brings us to this question. If DAP is getting involved, what do you think? When DAP is getting involved, first thing that has to come to your mind is psoriatic arthritis. Because psoriatic arthritis can involve the wrist, MCP, PIP, DIP. Everything can be involved.
DIP ઇન્વોલ્વ ક્યાં થાય? સોરિયાટિક આર્થરાઇટિસમાં wrist, MCP, PIP, DIP બરાબર, ત્યાં ઇન્વોલ્વ નથી થતો. wrist, MCP, PIP, DIP આ બધું થાય જ છે. તો DIP આના પ્લસ DIP એટલે સોરિયાટિક મારે જ.
Psoriatic arthritis actually produces such amount of arthritis, and as I told you again, this is an erosive arthritis. Correct. So these patterns and the more number of patterns should be clear. Now what you should not miss out here is what are the conditions where DIP joint is getting involved. So one condition I told you where DIP joint is getting involved.
Psoriatic arthritis.
Can you tell me another condition?
Multicentric reticular osteocytosis. Osteoarthritis.
Osteoarthritis can also
wrist
be
and
osteoarthritis can involve
MCP.
DAP, psoriatic arthritis can involve DAP, multicentric reticular osteocytosis can involve DAP. Even JIA, which is a pediatric thing, JIA can also involve DAP. So these many things can actually involve DAP, but when you think of DAP, psoriatic arthritis, OA, MRH have to come to mind. Correct? And always remember that osteoarthritis spares the wrist and MCP joint. It involves the DAP, but it spares the wrist and MCP joint. So OA spares the wrist and MCP joint, RA spares the DAP, first CMC, first MCP. When you are having psoriatic arthritis like picture, all the joints can be getting involved. Okay, this is also to be very, very clear. And now we bring to the last part, which where clinical questions are going to come. My questions are going to come in 4 ways. One is I can get a question of symmetrical polyarthritis. This is one question which I get. Symmetrical polyarthritis of the small joints of the upper limb. So this is one very, very common question that I get. Symmetrical polyarthritis of the small joints of the upper limb. You just have to look into two things. Less than 6 weeks, more than 6 weeks. This is only what you have to look for. When it is less than 6 weeks, it is called acute symmetrical polyarthritis of the upper limb. When it is more than 6 weeks, it is chronic symmetrical polyarthritis of the upper limb. Any acute symmetrical polyarthritis of the upper limb is considered to be post-viral unless proven otherwise. So less than 6 weeks, the first thing that has to come to your mind is PARVO V19 post-viral. That is the best answer. Okay, This is to be compared with an entity called undifferentiated arthritis. This is the other issue. So post-viral can be there, undifferentiated arthritis can be there, and remember, 1/3 of patients with undifferentiated arthritis can become RA. So 1/3 of them can become RA, but these are the two most important DDs under 6 weeks. When you go above 6 weeks, then of course it is chronic. The first thing is RA, and the most important DD is SLE and SLE-like arthritis. So this is going to be the most important DD. And here, what is going to come to your rescue? Erosions are actually going to come to your rescue. Okay, and also you have to keep in mind that psoriatic arthritis can present like this. Yes, psoriatic arthritis can present like this, but psoriatic arthritis will have involvement of which joint? The AP joint. So when you think of chronic symmetrical polyarthritis in the small joints of the upper limb, at your level, when you think of RA, SLE, and SLE-like and psoriatic arthritis, that settles the picture for you. Correct. This is one question that is come from the exam. Then the question that is coming from the exam is acute monoarthritis. That means single joint getting involved. Acutely, you are getting monoarthritis. Acute monoarthritis most commonly involves the knee joint, or it can involve the first MTP joint. So knee joint or your first MTP. Whatever it is, acute monoarthritis is always a question of septic versus crystal. So whenever you are having acute monoarthritis, it's a question mark. It's a question between septic and crystal. Crystal is CPPD, MSU. Crystal is CPPD, MSU. When the first MTP joint is getting involved, which is the coolest joint in the body, and as a reason it's getting involved with gout. It is most often MSU. So first MTP joint, acute monoarthritis, extremely painful. It's of course equal to MSU. When knee joint is getting involved, then you have to think of septic mode. Septic greater than crystal, I would say. And in crystal, CPPD can actually present like this. That is why CPPD has so many pseudos. There is pseudo gout, pseudo OA, pseudo RA. We'll come to that. So crystal is CPPD, septic, even gout can present like that later on. Body articular gout, everything is there, but septic more than crystal is what you have to think of. So when you think of acute monoarthritis, always keep in mind septic and crystal in mind. Chronic body arthritis, small joints of the upper limb, whom should you keep in mind? RA you have to keep in mind, psoriasis, SLE, and SLE-like arthritis you have to keep in mind. Then they can ask you this question on asymmetrical oligoarthritis. Okay, whenever you think of the word asymmetrical oligoarthritis, what should come to your mind? A peripheral spa should come to your mind. What is the peripheral spa, or what are the two peripheral spas that have to be always there in your mind? Reactive arthritis and psoriasis. Okay, so asymmetrical oligoarthritis, knee joint is going to be the most commonly involved one. These two things have to come to me. These are the only 4 patterns. If you know these 4 patterns, you are safe as far as arthritis is concerned. That is why I told you keeping this in the right pocket is the single most important thing as far as you as a student is concerned. So look for the pattern. Monoarthritis, septic crystal, asymmetrical oligoarthritis, peripheral spa, chronic symmetrical polyarthritis, RA, SLE, SLE-like arthritis, and psoriatic arthritis, acute symmetrical polyarthritis, post-viral arthritis. Don't smudge, you don't place this in the pocket. Once you don't place this in the pocket, you don't know the answer. You can still eliminate and complete the factors. So having got a wholesome idea, let's go to RA proper now. I think RA proper discussion will be more easy for you. Before I go to RA proper discussion, let me just show you this to tell you the importance, the humongous importance of what we are going to discuss. RA is a disease where time is gold, diamond, platinum, because platinum is dense, but then gold. 100% no doubt about it. When you find out RA, when are you going to figure out and start treating RA is going to make a lot of difference. See, if you start treatment now, this is how it is. Here means this is how it is. This is how it is. So as you take more and more time, it's going to be bad and bad, which means that about 2 years treating for RA has no point, because it is going to become chronic stabilized RA. And chronic stabilized RA means deformities will set in, and once deformities are set in, there is no point in treating RA. The best period to treat RA is inside the first 3 months, which is called as very early rheumatoid arthritis. This is where you have to catch all of the patient, treat the patient. But unfortunately, how many patients are getting treated at this point is a question mark. 3 months to 1 year is called early established RA, and 1 year to 2 years is called late established RA. There is value in treating at this point also, but of course the prognosis is not going to be as great when you treat it inside the first 3 months. So first 3 months, realistically, at least in the first 6 months, inside the first 6 months, we have to act to treat. Okay, so that's it. Before we start discussing RA, just try to keep things in perspective. Erosive, correct. Symmetrical, correct. Inflammatory, correct. Arthritis, correct. Synovitis, better answer. Erosive versus non-erosive, it is erosive. Deforming versus non-deforming, it is deforming. It is a proliferative synovitis. That's what we call as hypertrophic synovitis with hypertrophy of the synovium, but we call it the panus. And panus is causing erosion. Everything is what's happening. Let us try to look into the etiopathogenesis of the disease before we start discussing into the clinical features. So every rheumatological problem will have a set of genetic plus environmental factors, which will together be responsible for the single most important change, and from that change, everything will happen. So RA is a disease which is, as per the textbook, seen in 40 to 60 years, which is all rubbish, because we have started seeing RA from 23, 24, 25. We have seen a lot of patients. So peak maybe in 40 to 60 years, but we're seeing a lot of young patients with RA also. So not a big statement, but female male ratio is 3:1. Female-male ratio is 3:1. This is important because we have a very famous 9:1 ratio in rheumatology, which is a female-male ratio in a lot of rheumatological problems that you have to be knowing. In knowing that RA is not such a female-male disease, very often RA. So what are the rheumatological conditions where you get 9:1 ratio? Sjogren's, SLE, Takayasu, fibromyalgia, chronic fatigue syndrome, primary biliary cirrhosis. There are so many conditions like this, which are the important conditions which come to my mind, where you get a 9:1 ratio. And mixed connective tissue disease is one condition where you get a 15:1 female-male ratio. So MCTD, you get a 15:1 female-male ratio. SLE, Sjogren, fibromyalgia, Takayasu, and all those things, you get a 9:1 ratio. So let us start off. So genetic and environment. Inside genetic, what is the most important thing? So genetic, whenever we talk of, we divide it into XLA and non-XLA. So here XLA is all about this XLA DRB104. Very, very, very important. XLA DRB104 is a so very important question asked so many times for your exam. This XLA DRB104 in fact increases the risk by 5 times. Inside XLA DRB104, what you should be knowing is the DR beta chain hypervariable region. This DR beta chain hypervariable region is called as the famous QKRAA motif, QKRA motif. So this DR beta chain hypervariable region, the set of 5 amino acids, this is called as the QKRA motif. So HLA-DR-B104, the QKRA motif is the risk factor. And this QKRA motif is a shared epitope. You will study in immunology, it's a shared epitope between DRB104 and 14. That is the reason why DRB104 and DRB114 both are actually at risk of RA. So B104 and B114 both are at risk of RA. Even DRB101 also has a risk for RA. So 14 is there, 1 is there, 4 is there. 4 is the one asked for the exam. Shared epitope is between 1, 4 and 14. QKRA motif is also being asked for the exam. Okay, one more MCQ here is DRB113. DRB113 is protective. So previously we used to think 3, 5, 7, etc. protective. Now all that has changed. 13 is the only thing that has been found to be protective. So 1 for 14 positive, 13 protective, 4 very important. QKRA motif word never forget. Shared epitope is between 4 and 14. That is about the HLA part. Then we have the non-HLA part. Non-HLA part is all about this PADI4 and PTPN22, of which PADI4 you have to be very, 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 very careful. Because the central point when you are actually looking for in genetic and environment together, what do they produce means the central point that they actually are responsible for is abnormal protein modification. So what is the single most important problem if you're asking me in RA? It is abnormal protein modification. Abnormally modified proteins are coming up and they are being taken by animals and cells. So the abnormal protein modification, one very important thing is PADI4, peptidyl arginine deaminase 4. This peptidyl arginine deaminase 4 is very, very important because it is the one that is converting arginine to citrulline. So post-translational modification of arginine to citrulline. You know arginine is a normal amino acid, citrulline is an abnormal amino acid. So this abnormal protein modification leading to citrulline formation is definitely going to be very, very crucial here. That is why among the non-HLA things, PTPN22 and PADI4, of which PADI4 very, very important for these. Okay, no doubt. So genetic is clear, HLA, non-HLA we have discussed. We are going to environment. As far as environment is concerned, it is all about smoking. Single most important environmental risk factor in RA is smoking. Smoking is very bad. Smoking actually gives you a bad prognosis in RA because it is going to increase the risk for extracellular manifestations, everything. Smoking is going to increase the risk for ILD in RA. So smoking is going to increase the risk for ILD in RA. Smoking is associated with bad prognosis in RA, and smoking increases the PADI4 expression in the airway. That means more abnormal protein modification. So bad prognosis increases for ILD, PADI4 expression in the airway. This is extremely important to know because ILD in RA is more common in males and is more common in smokers. Everything in RA is more common in females, but ILD and also vasculitis. Vasculitis also in RA is more common in males, and ILD is more common in smokers also. Correct. That is why you get a very important question called smoking associated ILD in pulmonology. When you are smoking associated ILD, there are 4 answers to that question. What are the 4 answers to that question? Desquamative interstitial pneumonia, Langerhans histiocytosis, respiratory bronchiolitis associated ILD, ILD in rheumatoid arthritis. So ILD in rheumatoid arthritis, desquamative interstitial pneumonia, Langerhans histiocytosis, RALD. These are the 4 examples for smoking associated ILD. Crosstalk between pulmonology and rheumatology. A lot of crosstalk is there between pulmonology and rheumatology. They are connected in so many ways. So this is the environment. And in environment, we have one more thing to remember, which is an infection. And that very, very important infection is chronic periodontitis. Please don't go and write EBV, mycoplasma, CMV and all that. That is all not there. Chronic periodontitis caused by Porphyromonas gingivalis. So chronic periodontitis caused by Porphyromonas gingivalis. This is the other environmental thing. So HLA, non-HLA, environment, smoking most important, and this chronic periodontitis. Together, what are they producing? Together, they are producing abnormal protein modification. So that is our next starting point. So genetic and environment together are causing abnormal protein modification. So what is this abnormal protein modification? The classical examples for abnormal protein modification are citrullation and carbamylation. So the 2 classical examples are citrullation and carbamylation, and that is why we have this anti-CCP antibody, if you remember, and anti-carb antibody. So both are there in this. If you think that way, it's very easy. Now, abnormal protein modification means these abnormally modified proteins are going to be sensed by whom? The antigen presenting cells. So the APCs are going to sense them. Which are the professional APCs? The Langerhans dendritic cells are the most professional APCs. Also B cells, macrophages. B cells, macrophages, Langerhans dendritic cells. They are the three most professional APCs. This Langerhans dendritic cells will go and present it to the T cells. Okay, this is what happens. And T cells can secondarily activate B cells, and all of them will migrate to the joint. So they will all migrate to the joint. Okay, so here you have a very important question. This is called DCT interaction. This DCT interaction is very important in the pathogenesis of means cancer is rheumatoid arthritis. Innate immune system is also getting activated here, not as much as the adaptive immune system. It is the neutrophils that are also migrating to the joint. And together, what do they cause? They will cause synovial hypertrophy in the joint, synovitis, and synovial hypertrophy in the joint. Synovial hypertrophy leads on to Pannus formation, and this Pannus leads on to bone erosion. This is what happens in the disease. Okay, so I think this part is actually speaking very, very clear. So who is more important? Adaptive is more important. In SLE, it is the innate system that is more important. Here, adaptive immune system is more important. Now, keeping in mind that adaptive immune system is more important, let us try to see this DCT interaction now. This is the next major thing. Dendritic cell T cell interaction. So T cells are getting activated along the TH1 and the TH17 lineage. TH2 is not important in RA. It is important in SLE. Here, it is not important. It's TH1, which is much more than the TH17 lineage. From TH1, we have interferon gamma and interleukin 2. Of which interferon gamma is very important. From TH17, interleukin 17 is there. These two things together cause activation of the macrophage. And macrophage releases the central key pathogenic cytokine in RA, and that is TNF-alpha. So the central key pathogenic cytokine in every disease is important. In SLE, it is interferon alpha. In RA, it is TNF-alpha. That's why we have anti-TNF-alpha drugs and everything. So it is TNF-alpha that is being released. What does TNF-alpha do? TNF-alpha activates the osteoclast. Okay, activates osteoclast. That is why we get a lot of osteoporosis. The moment you think of osteoporosis in rheumatology, it is osteoporosis is an endocrine topic for your knowledge. And in rheumatology, there are two conditions notorious for osteoporosis. One is RA and second is ankylosing spondylitis. So we have activation of the osteoclast by this pathway called rank ligand rank interaction. So that you will again study in osteoporosis, rank ligand rank interaction pathway. That means rank ligand is being released by a lot of activities which will bind to rank receptor on the surface of osteoclast and activate. TNF-alpha also inhibits osteoblast. It inhibits osteoblast by this pathway called DKK1 pathway. So it inhibits osteoblast by this pathway called DKK1 pathway. So that is what it does. This is the complete total of what happens in rheumatology, starting from genetic and environment to synovitis, synovial hypertrophy, and Pannus formation. Clear? I think every single point is very important inside this, and we get lots and lots of questions on this. That's what I have been trying to discuss also. So please keep in mind HLA-DR B104, this quick-gram motive, and DR-beta-C and hypervariable region, shared epitope between 4 and 14. All the HLAs we have seen, PADI4 is very important, translational modification of arginine to citrulline. HLA-DR we have seen, PTPN22, PADI4. Okay, this is what we are actually seeing. That is the strongest environmental risk factor, smoking. That increases the PADI expression.
HLA-DR B104, 114 and 101 and a protective 113. Non-HLA PADI4 and PTPN22. Okay. कोई इंटरेस्ट નથી જો નો વાગે બંધ કરી દે બીજું હું હાલો
On the airway, smoking. What increases the ILD? Smoking. What has bad prognosis? Smoking. Siliconol is there, but it's more important than smoking, so you can forget it. Alcohol and OCP mild protection. Despite keep in mind, alcohol has mild protection in both SLE and RA, but not significant to be taught in class. OCP I want to tell you because OCP is very strongly associated with SLE. So that is why OCP is not associated with RA. You must just keep in mind. Because always when you study RA, you have to compare it with SLE. What is more in males? ILD is more in males. Vascular is also more in males. Pregnancy seems to be good in this disease because interleukin 10, which is a very important for anti-inflammatory cytokine, it seems to be good. And SLE use, malnutrition can go really bad in pregnancy. RA is not. Infections, no link from any of this. It is only chronic periodontitis, which is caused by Porphyromonas gingivalis, that you have to keep in mind. Okay, so I think that is about the genetic and environment. Now, before we go to anything further, we need to be looking at a very, very important discussion. And the important discussion is what are we going to do with the patient whom we are going to see. So let us try to come to that point. We are going to talk about the student.
હાલો ભાઈ કોઈ જોતું નથી આપણે શું કામ રે બંધ કરો લાઈવ